So, good morning, good afternoon, good evening, wherever you are, and welcome to this last session of the TechNet webinar series on achieving and maintaining the global elimination of maternal and neonatal tetanus. The topic we'll discuss today is validating and sustaining maternal and neonatal tetanus. You can listen to this session in French and English. To do so, please click the globe icon that you will see at the bottom of your Zoom window and select the language in which you'd like to listen to this session. A presentation will be done in English and another one will be done in French. So you can switch, you can use the interpretation system to switch the language. Now I'm going to say that in French for our francophone audience. Bonjour à tous et bienvenue. Vous pouvez écouter cette session en français ou en anglais. Pour cela, vous pouvez cliquer sur l'icône en forme de globe et sélectionner la langue dans laquelle vous souhaitez écouter cette session. Cette session donc il va y avoir deux présentations, une en anglais et une en français. Vous pouvez donc changer les langues en vous mettant sur le canal anglais ou français selon votre choix. We'd be happy to know who's with us today, as usual, and so you can already introduce yourselves in the chat box. Tell us your names, where you're from. That would be great for us to see, and also for everyone who's participating to see who's with us. You can also use the chat box if you have any technical issue with sound or anything, and I'll do my best to help you. If you have any question during the presentation, please use the Q&A box. It's also, the link is also at the bottom of your Zoom window. You can ask your questions at any time of the presentation, and our panelists will answer them after their presentation. Finally, this session is recorded as usual, and we'll share with you the links next week, probably the links to the video as well as to the slides by email. We hope you'll enjoy this session and find it useful, and I'll give the floor to Nasir. Nasir, the floor is yours.
Yeah, thank you very much, Alex. And again, welcome participants to the last and the third and final series session of the MNTE Capacity Strengthening Webinar Series. Particular thanks to those who were able to participate in the previous two sessions, as this is supposed to be a kind of continuum. From we looked at the clinical aspect to the strategies, now we're looking at the assessment. So it's really great for those who are able to follow the three sessions. I'm Nasir Yusuf, and I'm the focal person for MNTE, sitting in the WHO headquarters in the Department of Immunization, Vaccines, and Biologicals here in Geneva. Just quickly before we start the presentation, to say that we've got our moderator, Dr. Francois. Then the presentations are in two parts. The first part will look at the assessments leading up to pre-validation assessment. The assessments moving from pre-validation to the validation survey. So the first part will look at pre-validation assessment and to some extent post-validation assessment, while the second session part of the presentation will be focused on the validation surveys. I will be taking the first part, while our colleague Palenfo Dramani, who sits in Ouagadougou with GSI, will be taking the second part. Now, this session, it's aimed at bringing to the attention of our country colleagues, Ministry of Health, partners, WHO, UNICEF, all the other technical partners at the country level, for them to really understand the assessment continuum within the MNTE initiative, starting from the time they identify the districts for SIAs through to the pre-validation to the validation. This session is not meant to turn colleagues into surveyors and supervisors for the assessment, but to let you know the critical milestones and how to plan for those milestones timely and adequately. The human resource admin and financial implications, the technical support needs, and of course, the leadership in terms of the different assessments. So with this, I'd like to hand over the mic to Francois, who is our moderator. Over to you, Francois. Thank you.
Thank you, Nasir, for your introduction. Hello to everyone present for this webinar. And I would like, so as Nasir said, we have a first session that will last about 45 minutes on pre-validation and another session that will last 45 minutes on the validation survey itself. Provided the pre-validation has concluded, the country is ready for the validation survey. For the pre-validation, many of you may have gone through it attending today. We know that the pre-validation takes place when, after having done SIAs in high-risk district and good routine in other districts, the country has been declared ready for doing a pre-validation. So we're going to hear Nasir now presenting the pre-validation process and the key element of this validation to make it conclusive or leading to some activities, corrective measure. Over to you, Nasir.
Thank you very much, Francois. Next slide. Yeah, thanks. So again, the assessments and their objectives. Now, assessment is part and parcel of the global initiative. We've got periodic assessments and one-off assessments. The periodic assessments are the NT risk assessment we conduct from time to time to identify if we have high-risk districts. And then we've got the one-off assessments, that is the pre-validation assessment, the post-validation assessment, and of course, the validation survey. So what are the objectives of this first assessment, which is the neonatal tetanus risk assessment? One is to identify those high-risk districts in which we'll target women of reproductive age with rounds of SIAs to bring up their immunity against tetanus. Secondly, to identify poor performing districts where we conduct our pre and post-validation assessments, to identify the poorest performing districts for our validation survey. Now, the pre-validation assessment is conducted in the poor performing district at least 1 year following the completion of the 3 rounds. And then the validation survey is conducted once we conclude through the pre-validation that the country or part of the country may have eliminated neonatal tetanus, and therefore we go in to verify through a validation survey. The post-validation assessment is something recommended by the WHO says that every 5 years, countries should use a standalone or an integrated assessment into a program review to assess core indicators and the health system at district health facility and community level, just to reassure themselves that elimination is being sustained. Next slide. Now, as I said, the assessment is a continuum. We assess, take action, move to the next. And these are the critical milestones. Like I said, once we have the 3 rounds completed, we move to the next step, which is the pre-validation. But the 3 rounds, we must have admin and post-campaign coverage data that shows that in every targeted district, we have at least 80% coverage for TD2+. And the country itself must be convinced that the work they have done is enough to have led them to validation. And then they move to the next step by inviting WHO and UNICEF to conduct desk review and data review. And then once those show that validation has taken place, we now move to the pre-validation assessment, which involves going to the field in selected districts and looking at the system there and then reviewing their data. Now, once the pre-validation in those selected poor performing districts show that indeed the country may have eliminated, we now use the LQAs, that is the Lot Quality Assurance and Cluster Sampling Survey, which is highly technical and statistically based survey method to finally validate the country. Now, once the validation has been concluded and its outcome is that the country indeed has eliminated, we now give the country this thing that yes, this country or part of the country has eliminated maternal and neonatal tetanus. But immediately after that, one of the recommendations that will come out is that the country should develop a sustainable maintenance plan and implement this plan. And then annually, we do this NT risk analysis just to be sure that we're on the right track in terms of sustaining evaluation. And you can see the arrow beneath. In all these processes, WHO, UNICEF, HQ, regional office, and country offices will provide technical and in most cases financial support. Next slide. Now, we start with the pre-validation. Now, just by way of background, so the pre-validation is the second critical milestone in the continuum. It is conducted, as I said, when the country has conducted the 3 rounds and they have reached the target coverage of the desired coverage in the high-risk districts. And as I said, it is conducted at least 1 year after the completion of the rounds of SIs, so that women would benefit from the impact of the vaccination before we go in for the validation. It is a joint exercise led by the government, but supported by WHO, UNICEF, UNFPA, and other partners. Next slide. Now, the main objective of the pre-validation assessment is to confirm that all the districts are at low risk for maternal and neonatal tetanus, and therefore the country is ready for the validation survey. The specific objective is to identify the poorest performing districts and then undertake field visit to these districts to verify the risk status. If the risk status is found to be low, then we now select the districts where the final phase, which is the validation survey, will take place, and then preparation starts. Next slide. Now, there are several steps in preparing for, conducting the pre-validation survey. The first is to collect core and surrogate performance indicators over the previous 3 years before the assessment. And this will include, in addition to this, the surrogates will include human development indices, which again we'll discuss in more detail later. We have all this in the WHO guide. And then various data sources are used from admin to household surveys. And then the coverage data are based on doses, not the number of rounds. This is very important because we've had situations where the coverage are reported in terms of round, and we're not sure when you say 3 rounds, whether the individual woman had the first, the second, and the third. But when we record this by doses, it enables us to say at least in this particular district, at least 2 doses or more have been achieved, 80% have been achieved in this thing, which by round will not tell us. Next slide, please. So now the next step is the initial risk review of data. Just to be sure that if they are missing data on the spreadsheets from the district, if they are questionable data, for example, 100% coverage, in some places we have 200, 300% coverage. And then if the district have NT rate that is 1 or more per 1,000 live births. This is very important because the moment, in spite of the 3 rounds of the SIS, if we find a district that has 1 or more NT case per 1,000 live births, it means that the country is not ready for the assessment, and that the country may not have eliminated tetanus. This is very important. And then to help identify the poorest 3 to 4 districts where this will be, the assessment will be conducted, which focus on having a cumulative population of at least 10,000 live births. Now, next slide, please. And the third step is the field visit. So the previous step was to do desk review of data and other relevant documents. The next step following that is to go to the field. So the field visit is very pivotal to the assessment because it allows the collection of additional data at the district, health facility, and community level. It allows the interview of immunization, maternal and newborn health, surveillance focal persons at the district and health facility level. Also allows the interview of stakeholders at the community level, including traditional leaders, traditional birth attendants, community health workers, and all the rest. Also an opportunity to look at the vaccine and cold chain data management practices in those places. Where opportunity avail themselves, we can also observe vaccination session. Next slide. Now, the fourth step is to consolidate results from the data review and field visit. So we've done the desk review, we've gone to the field to do the assessment. Now we need to consolidate and analyze this data and make sense of it. Now, in recent times, at least in the last 5 years or thereabout, we now have the opportunity of using the open data kit called ODK. This is used, this is a program that's used in handheld devices, Android powered, including tablets and cell phones. So it allows for real-time data collection and transmission, and that the data transmission to the central server immediately following the completion of the questionnaire is made possible. And this allows the data to be checked for errors, missing data, and all the rest, and allow for immediate corrective measure. Next slide. Now, the fifth step is the debriefing on the conclusion. So we've done the desk review, we've visited the health the district, the health facility, we've interviewed women at the community level. Now we have analyzed the data, the key findings, the conclusion. We now have to debrief the key stakeholders because this assessment in the first place was requested by the Ministry of Health. So we've conducted it. We need to go back to the Ministry of Health along with its technical partners and debrief them on our findings and conclusion, and of course the next step. So if the assessment, for example, could not generate evidence of elimination, then are we going to conduct additional rounds of SIS in those districts where we think they are still at high risk, and then implement measures to close these gaps? Now, if the assessment concludes that, through evidence, data evidence and analysis, that the district that we visited have indeed eliminated, then we'll now use the opportunity to prepare for our pre-validation, the validation survey as a recommendation as the next step. So the sixth step, next slide, please. The sixth and final step is we've done the debriefing, so we really now need to articulate all our work in terms of a narrative report that clearly shows the rationale for going about it, something, the assessment, the objective, and then the methods and all the rest, and recommendation, of course. Next step, as I said, the next step will depend on the conclusion, whether the findings are in line with elimination or not. If in line with elimination, the next step will for the country to start preparing for validation survey. If it's not in line with elimination, we will recommend that the country should conduct additional activities, especially SIAs in districts that are deemed to still be at high risk. Next slide. So now we need to quickly look at the planning. As I mentioned, the planning is very critical. Now, it's when countries develop their plan, the first thing they can do is, like I said, is to identify the high-risk district for SIAs. Now, how they move to the next step, which is pre-validation, will depend on the outcome. So countries should be prepared for this, and as they move from one phase to the other, it should be in their plan in the course of the year. For example, a country that has finished conducting the 3 rounds this year, it means when they are developing their plan for next year, they should be preparing for pre-validation assessment while discussing with the technical partners to be sure that that is the right decision to go into based on the data available. Now, the first thing is for the Ministry of Health. When a country believes that they have eliminated, the first step is for the Ministry of Health to send an official request to WHO, to the rep, requesting for technical support to conduct the pre-validation assessment. And then once the country office receives this request, it will send a request to the regional office with copy to the headquarters so that we can also begin to put this in our calendar. Now, the country team of Ministry of Health, WHO, UNICEF, depending on the country, will initiate a kind of bi-weekly meeting to start preparing for, because these assessments require intensive preparation. So through these bi-weekly meetings, we're able to prepare adequately. If there are issues, financial, admin, logistics, we're able to quickly identify and correct the whatever gaps we've seen. And then there should be a budget to be drafted for the operationalization of the assessment. And this is usually sent to WHO and UNICEF. Depending on the country, the funding for the pre-validation may be coming from UNICEF or from WHO. Now, technical preparation, based on the risk analysis, we should by now be able to select the 3 to 4 districts. In some countries, it could be up to 5, depending on how the country perceives the risk. Some countries will want the districts to at least be kind of sort of geographically spread. But again, it depends on how these districts are perceived in terms of performance. And then the country needs to review and adapt the field visit checklist, the ones we call questionnaire. And as I said, we currently use the ODK. We no longer use the paper-based. And then planning should be made, preparation should be made to train the assessment teams. This is very, very important. As I said, these are independent assessments. Next slide. Now, a number of logistic considerations. For a pre-validation, from the time the team of international assessors from regional office, from HQ arrive at the country until the debriefing of the stakeholders, we need at least 10 days. I've seen situations where countries think you can just do this in 3 days. It's not. So please, when we're planning this, let's think of at least 10 days. In some countries, because of the challenges in traveling from one place to the other, it might even take more than this number of days. And then the field data collection, we must dedicate at least 3 days, because we're going to collect data at the district health department, as I said, interviewing key focal persons at that level. We're going to collect data in 2 health facilities in each district. And then we're going to go to the community to collect data from women that gave birth to children, that gave birth in the 2 years prior to the assessment. So you can see that there's no way we're going to be able to do all this in less than 3 days. Now, arrangements should be made for the trainer. As I said, training is very, very, very key to these assessments, because it's not an assessment where you just go in and start. There are some techniques from the identification of the households, moving to the next one, the interview techniques and all the rest. Very, very important. So training is such a key aspect, to the extent that beside the theoretical training in the conference room, we also go to the field to conduct a mock exercise, just to be sure that what we've taught theoretically, when it comes to practice, people are able to, so that we don't train people and then they go to the field. In practical terms, they are not able to conduct the assessment according to the guidelines. Then there should be arrangement for the field data collection. Teams must be assigned to districts. Transportation arrangements must be made, both for going to the district and functioning within the district, moving from district to health facility to communities. The human resources, very, very important. I mean, the different resources from human, transport, community engagement, and the implication of this engagement within the district. Communication plan among the teams, because teams need to communicate with each other and communicate with maybe those who are sitting in the central level. And then arrangements must be made, as I said, using the ODK. You need a data manager to whom all the forms, completed forms, will be transmitted to, and who will be looking at the data for missing data and errors. Next slide. Now, I talked about the NT risk and analysis. It's a very, very critical aspect of the data, because we can know whatever we're doing, whether we're going to conduct rounds of vaccination campaigns, we need to be able to say why we're going to a particular district. The reason for going to the particular district is because we feel those districts, based on available data and in-depth discussion, we have identified those districts to be at high risk. So we really need to understand the risk analysis process. So there's a scheme recommended by WHO and UNICEF for the analysis, and this will normally look at core and surrogate performance indicators, and this includes the the surrogate indicators include the DTP or penta coverage. The core indicators will include the TD2 plus coverage among pregnant women through routine immunization, and also through campaigns. The antenatal care visit, at least the first visit, which is a surrogate indicator. And then we've got the skilled birth attendance, that is institutional deliveries or deliveries by skilled persons. This is a core indicator, very, very important, as we alluded to during the second session of this webinar series. These are the key strategies: the vaccination strategy and the clean delivery strategy. So you can see now that in conducting the analysis, we're trying to see the coverage of this, of performance indicators for these different strategies. Next slide. So this is just an example of the kind of analysis we conduct and what the outcomes are. So if you look at, for example, you have the different districts on the first column from A to N, and then the date of the, the date that the indicators are covering. So you look at, for example, the DTP3, the reported TT2 plus among pregnant women, antenatal care visit 1, and those at least those less than 4, and then delivery by trained birth attendant, that is the skilled birth attendants, and then these first 4 columns or 5 columns are all admin data. But when we now move to like the clean delivery, the skilled birth attendants and all the rest, most times we rely on data from household surveys, be it the demographic and health survey, or the mixed multiple indicator cluster survey. So we use data from these different sources too. So this is just an example. So when you look at this, you'll be able to see which are the districts that are probably at high risk. Those will be the districts with low coverage for these different indicators. Next slide. So again, sorry for the interpreters. I know this is quite difficult, so I'm not going to go into details of this, but our colleagues, the audience of this particular session, most of them are very conversant with it there, so they are used to it. So what we have is the different indicators are calculated, and based on the coverage, they are scored. So small grouping, you say, okay, those less than 50%, the score will be 0. Those between 50 and 79, the score will be 2, and those above 80. So it depends. And again, the weight given to the different indicator will depend on whether they are core indicators. The two core indicators, as I said, are TD2 plus coverage, whether through routine and skill bat attendant. So those are the ones with the big, the higher scores. So that's why you'll see that the 80% for TD2 plus is at 4, and for skill bat attendant, while like the surrogate indicators such as Penta and the TPU and ANC will be maximum of 2. So this is, again, I don't want to bog you down with it because you've got the guidelines where these are clearly highlighted. Next slide. So this is an example of the scoring. So as I said, if you look at the DTP, you can see 80% and above is given a score of 2. Then 50 to 79% a score of 1. Less than 50%, 0. And subsequently for all. So at the end of the day, the total scores are added. And then those districts, excuse me, those districts with the lowest scores will be selected. For example, if looking at this table now, I would go for the district A, maybe district is it G or G, maybe district I, or so forth. Now we have this scoring, we have the analysis and everything. Given the gaps we have in terms of data, quality of data, at times we also have to rely on the local knowledge. So please, this is one thing that what you will notice is that in the analysis, we mentioned earlier on and in the previous session that the NT rate, and I alluded to it during this presentation, that the neonatal tetanus rate of less than 1 per 1,000 live births in each district will determine whether we progress from completion of SIAs of the campaigns to the pre-validation assessment. So if we have districts that have neonatal tetanus rate of 1 or above per 1,000 live births, those automatically we cannot progress because it shows very clear indication that those districts are at high risk. But again, those of us who have been in the field who have been told that the neonatal tetanus surveillance is the weakest of all the vaccine preventable disease surveillance. And in most cases, we are only able to capture just 10% of the number of neonatal tetanus cases. So when it comes to this scoring, you can see that we did not include it here because, again, it's because of the gaps we have in the surveillance system. You might have districts that are not reporting, but what is the surveillance quality? So that's why obviously we do not put it in this thing. But again, the final decision, we still have to bring it in, but even though we don't have it in the scoring here. So next slide, please. So this is just to talk a bit about the tools we use. So we've got the assessment tools. You're all familiar with this. We have the 3 main tools. The first one is the tool that we use at the district level to interview the colleagues at the district level, as I had earlier alluded to in previous slides. We have a tool that we use at the health facility level, and then we have the tool we use at the community level for the rapid convenience survey. Now, at the different level, what are the activities? First, at the district level, we quickly review relevant data and technical materials covering immunization, specific to maternal and neonatal tetanus immunization, looking at maternal and newborn health. As I mentioned earlier, clean delivery is one of the strategies. Therefore, we need to work with this program and also the surveillance system, any other relevant addition. And then we interview relevant focal persons at this level, at this level, and use the opportunity to look at the cold chain and vaccine and cold chain management. At the health facility level, we're using the same approach, but this time we review their data to look at the coverage at the different different health facilities and interview people as well. At the community level, we conduct rapid convenience survey in selected communities. In each health facility, we try to, okay, let me just go back. If you look at this scheme here, in one district, we select a good performing health facility and a poor performing health facility. And then in each health facility catchment area, we select 2 communities that should be at least 10 kilometers away from the referral health facility. So we don't want to choose communities that are just behind the health facility, because the tendency is that they have access to the health facility and so it will bias the whole distance. So it's very important, the selection. Now, at the community level, we identify randomly, moving from houses to houses, randomly to identify women that gave birth to babies in the 2 years or 24 months prior to the survey, to see what was the outcome of the pregnancy and the different intervention, especially did the mother receive adequate doses of tetanus toxoid containing vaccine, whether at least 2 doses, whether during that pregnancy or previous pregnancies, including during mass vaccination campaigns. Was the child delivered in a health facility? Who delivered the child if outside the health facility? Was it a skilled birth attendant? Was it a traditional birth? Was it relatives? How did they manage the umbilical cord in terms of treatment? What did they apply and all the rest? So very, very important. Next slide. So this again, an example of the categorization of health facility. Like I said, when we get to the district, we work with the district level and select 2 health facilities, 1 poor performing and good performing. So this is an example of the data we'll use to be able to select the different health facilities. Next slide. Yeah, so finally, once we have collected our data, we've done the analysis, our findings and everything, we need to reach a conclusion. So the first thing is, in the district that we went to, based on the information we collected, especially the rapid convenience survey, is in that district, among the women, total number of women. So now we said in a district, 2 health facility, in each health facility, 2 communities. It means we're talking about 4 communities in each district. Now, the total number of women that were interviewed, that were surveyed, we have 80% or more coverage of at least 2 doses of tetanus toxoid containing vaccine for the most recent baby that was delivered in the 2 years prior to the survey. If the answer is yes, then we say elimination has been achieved, and therefore we recommend that a validation survey be conducted. Now, if on the other hand, even if this is the vaccination is less than this threshold, but the skilled birth attendant is at least 70% and above, we say that validation has taken place. If both, so it's either both or one of them, we say elimination has taken place. If on the other hand, the answer is no, that the TD2 plus is less than 80%. The skilled birth attendant is less than 70%. In both cases, then we say elimination has not taken place, and therefore we'll make recommendation that corrective campaigns or any other opportunity to boost population immunity in those districts be conducted before we take any further action. So I think that will be the end. Next slide. I think that should be the end of my. Yeah, sorry. Now, we mentioned post-validation assessment. You see that I have only one slide on post-validation assessment because the methods, the tools are exactly the same as for pre-validation assessment. However, the objectives differ very widely. So, for example, what is the objective of a pre-validation assessment? As I mentioned earlier, is to assess if the country has eliminated maternal and neonatal tetanus. What is the objective of the post-validation assessment? Is to assess if the country that has been validated for elimination is actually maintaining elimination. Now, in terms of the status of the countries where these are conducted, the pre-validation is conducted in countries that are yet to achieve elimination, while for post-validation assessment, the assessment is conducted in those countries that have been validated. And again, in terms of selection of districts, it's practically the same thing. Again, we can also always manipulate this at the country level to suit the prevailing context of the country. Then what are the indicators? For example, for pre-validation, I mentioned that the TD2 plus coverage should be 80% and above, and that the skilled birth attendance should be 70% and above. Now, for the post-validation, we reduced that a bit. We still continue to maintain 80, but in some countries, we might adjust to 70% for the TD2 plus. And then the skilled birth attendance, we've reduced this to 60%. So you can see that the threshold for post-validation are not as high as for pre-validation. And then what decision do we arrive at for the two different assessments? For the pre-validation, we answer the question, has the country eliminated MNTE or not? Whereas for post-validation, the question is the country maintaining MNTE status or not? And then what are the steps we take, the next step after each of the assessment? For the pre-validation, we conduct validation survey if we believe elimination has taken place, or we recommend corrective measures where we think elimination has not taken place. For the post-validation, again, unlike in polio, where we will say, okay, now maybe the country is no longer, we want to withdraw the elimination lesson that we give to the country. No, we don't do that. Regardless of the outcome, all we can do is to recommend measures to strengthen the maintenance of the status. If the country is doing okay, we make recommendations to reinforce what they are doing. If we find gaps, we highlight these gaps and advise the countries on how to close this gap to ensure that they'll be maintaining and continue to maintain elimination. So next slide. I think this is my last slide. Thank you so much. So let me stop here. Back to you, Francois.
Thank you, Nasir, for your presentation. My first comment is to note that there was 29 different countries attending the session, and out of the 29, 24 had already achieved elimination, and I guess we're more looking forward on how do you validate you have maintained elimination, and what are the guidelines, etc. And only 5 countries were still to achieve elimination and not ready really for pre-validation. That's fair. I would, so maybe, do you have any? I've noted a certain number of questions in the chat box that I can answer, because unfortunately some have not read it except the person asking for it, or the author and the panelist. Do you have any specific questions, the audience? We have about 10 minutes, but we may take another 5 minutes, especially because we need to answer questions on post-validation and maintenance. Over to the participants. Any question? Okay, Simpara, please. Simpara, can you unmute yourself and ask the question? If not, Dauda, can you answer?
Ok, merci bien, Monsieur François. Merci également au présentateur. En fait, j'avais deux questions. Je suis Dr Daouda Sempara. Donc, je suis le webinaire depuis le Congo-Brazzaville. Je voulais savoir quand est-ce que l'évaluation post-élimination est réalisée. Un pays qui a obtenu le statut d'élimination, quand est-ce qu'on évalue après l'élimination son statut? Donc, la deuxième question, ça c'est par rapport à la situation.
When we do the evaluation post-assessment, if the country, and apologies, the interpreter didn't catch the question. I just wanted to know if you can go into details about this, because it wasn't very specific. So if you could give us just more examples about these problems.
Could you please answer?
Yeah, thank you very much, Mr. Dauda from Congo, Republic of Congo. Yes, I think his questions are quite pertinent. Like I said, I just put one slide on on post-validation, but that may somehow have minimized the importance of post-validation assessment. As Francois mentioned, almost 90% of the participants in this session are from countries that have been validated, and countries have been doing a lot of work to ensure that they sustain their validation, elimination status. So in terms of the periodicity of conducting the post-validation assessment, the recommendation of SAGE, that is the WHO Strategic Advisory, this Strategic Advisory Group of experts. This should be conducted every 5 years. And where possible, if there's already a planned program review, this should be integrated into a program review rather than having a standalone assessment. Unfortunately, this recommendation, the uptake had been quite low, and very few countries have conducted this compared to the number of countries that had been validated for elimination. So it's every 5 years. So that should answer the first question. The second question is, I mentioned that if the outcome of the post-validation survey is positive, that is, the country is maintaining its elimination status, will make recommendation to reinforce those things that they're already doing to make sure they continue to sustain. If, on the other hand, the findings are that the country, maybe in a certain districts, shows that the country is no longer maintaining its elimination status, as it's currently may be the case, because each time we analyze the data through the EGRF of countries, we continue to see districts with 1 and above number of NT cases per 1,000 live births, despite the countries having been validated for elimination. So in those kind of districts, we'll advise that the more detailed analysis, more data should be collected, and then more detailed analysis should be done across all the districts, because you might find that we went into maybe 3 or 4 districts. So it could be that those districts we didn't go to, some of them have the same problem. So we advise the countries to conduct corrective measures. Now, this word corrective measure, I think that's where the questionnaire is a bit at this. So we expect that where possible, they should conduct at least 2 rounds of SIAs, targeting women of reproductive age in those districts that have been identified to be of low risk. Of high risk. Now, if for resource reason they are not able to, then they should use routine immunization, the routine immunization system to also target these women and also expand and expand their outreach and mobile listing to provide this thing. So whatever other option for them outside of SIS could be used. For example, the big catch-up is going on now. So if countries find out districts that are at risk, this is an opportunity to also target women of reproductive age in those districts. So I think, I don't know if I managed to answer the question.
Okay, thank you. Time is quite running. Another, but there are important questions for many of the participants. Now there is a question also by Mamadou Balde to everyone. Quel est le seuil de notification?
What is the notification threshold for the pre-validation exercise? And it goes back to the other question, on what basis can we ask for pre-validation? And the other question is, what is the case for the Republic of Guinea?
Let me start. Now, I guess he's talking about the soil, that is the threshold.
Yeah.
Yeah, for the pre-validation, is it?
Yes, yes. What's threshold for considering that all districts are low risk?
Yeah. So as I mentioned in the course of the presentation, the first thing is to be sure that all the districts have less than 1 NT case per 1,000 live births. That is the first, and that all the districts have TD2 plus among women of reproductive age of 80% and above, and that skilled birth attendance is 70% and above in all the districts. If you have this kind of situation, we say the country may have eliminated MNTE, and therefore the next step is to go and conduct a validation survey to verify that this thing. Now, the next question is what time to conduct the pre-validation assessment. As I mentioned, the first thing is for countries to identify high-risk districts and target those districts with 3 rounds of TTCV mass campaigns. That is the first thing. Once they have completed that, a year after the last round of this campaign, they'll conduct risk analysis. And then once they meet this threshold that I just mentioned, they should proceed. So that is the timeline. Of course, countries take several years to conduct the campaign, some 3, 4, 5 years because of resource availability, competing priorities, and all the rest. So, Mamadou, I don't know if I managed to answer your question.
Maybe can I complete?
Yeah, please go ahead.
So basically, when you talk about pre-validation, it means that before the pre-validation takes place, there was a review of the performance, the risk and the performance of all districts in the country. This is valid for both in pre-valid before they achieve elimination on post-validation. Now, when you look at this risk review with media indicators, if you have not yet achieved elimination, you have to achieve 80% TD2 protection or SBA of 70% in all districts before you can pretend to a pre-validation. And you will review districts that you consider that high risk and you look at SIAs, you look at when the SIAs have been conducted, what was their performance, and you look at other districts that didn't conduct SIAs because they consider low risk through routine, but the combination should conclude all districts are low risk. When you are in post-validation, it becomes a bit lower because, as you know, there is underestimation of the TT protection, and there is a lot of private sector for clean delivery. So we consider that you have to lower the threshold in post-validation to 70 and 60 respectively. Now, when you do the post-validation, is either indicator of that threshold will be acceptable, or sometimes you're lucky both are there. Over to you.
Thank you very much, Francois. I don't know if we have further questions, taking into consideration that we have the second session of the presentation.
So maybe I'm sure there are many other questions.
Yes, so maybe we should go to the second. If they still have questions on the first, we can always come back.
Sorry?
I said maybe we should go to the second part. If people still have questions on the first, we can also continue to answer.
To the second part is how do you conduct in practice an effective validation survey to validate that districts are all below 1 per thousand, the threshold live birth, the threshold established by WHO. Over to you, Palinfo.
Hi, everyone. Thank you very much, Francois and Nasir, for this first part. And I'm very happy to be part of this meeting and keep all the people well participating. I will have the second part in French, while the slide will continue to be displayed in English. Donc,
So following the first part, I would say that now we're going to talk about the validation survey of elimination of MNTE. This survey is the last assessment to really make sure that the country has eliminated or not neonatal tetanus, or if part of the country has done so. So the survey is recommended by the pre-validation. So it's a follow-up on pre-validation, as Nasir said. The decision is made whether we should go to the survey assessment during the pre-validation exercise. And this survey can be commissioned by the country when the main indicator for neonatal tetanus is below 1 for 1,000 live births in each of the districts of the country. So when the country has reached this stage and has done the pre-validation, they can ask for validation. So the survey follows the net quality assurance sample, is recommended by WHO, which has elaborated a guide with steps to be followed, and it's standardized, and it's the same guide, the same method that is applied in all the countries for this survey. So the LQA-CS, as I said, is going to allow to measure the number of deaths due to neonatal tetanus, and it's going to verify if that number is really one case for 1,000 live births in the country or the region. So this survey, this method ensures that the mortality rate due to neonatal tetanus assumes that the rate is very close to the incidence, because we know there's a very high mortality rate in those cases. So we try to assess the incidence as well. So this survey is going to go through live births. So in the statistics, we're going to, in the survey, we're going to analyze the data from live births that have happened in the 12-month following the survey. So that's what we're going to use to measure the mortality rate. And the deaths are going to, the neonatal deaths are going to be investigated to be able to determine if these deaths were caused by tetanus or not. So we need to remember that this survey is not going to give us a value, and the interpreter is sorry, but the sound is not great. So the rate should be less than 1 case for 1,000 live births, because this is an LQA, as you know. So at the end of the survey, the number of deaths due to neonatal tetanus, which will be detected, is going to be compared so there's a number of decisions to be taken. We compare the number of deaths by tetanus during the survey and bring it closer to this threshold for decision. This will allow to say that the country has eliminated tetanus. And the interpreter wishes to apologize, but the sound is not good enough for interpretation. Sorry about that. Sorry for interrupting, but the sound is really cutting up. I don't know if it's from the connection or something else, but the interpreters are not able to follow and translate towards English. So I would say maybe move away from the microphone a little bit and maybe cut your video so that you have more bandwidth. It's great to see you, but unfortunately the connection is not good enough. And we're going to try. Thank you. Is it a little better now? So just let me know in case there's a problem. So I was saying that we use this step, which is examining the quality of data. It's about the same process as pre-validation. We'll have the indicators and the core or additional indicators. We're going to look at those indicators and take them from different sources. Some will come from the vaccination data, some from the blood samples from the mother or the child, and other from surveys as well, the previous surveys. So when we examine those data, we have 3 possible outcomes. The data clearly support elimination. That means the data is complete, it's well managed, there are good quality data, and we were able to find that all the districts had less than 1 case incidence due to neonatal tetanus for 1,000 births. So when the data is well managed, we can already declare elimination. But data can indicate that the elimination has not been achieved, or that it is highly unlikely that elimination has been reached. And in this case, we implement additional measures to achieve elimination in order to come back later and do the validation. The third scenario is that the data say that possibly we have reached elimination, but we're not exactly sure about a couple of factors. So at this time, we're going to implement a process to do a validation survey. When we look at this data review, we have those key indicators, we have the additional indicators and the other indicators. And I won't go into too much detail because Nasia talked about that enough, but just note that the first group is linked to the vaccination program and surveillance programs for clean deliveries. The others we're going to look for in the AIS, the vaccination campaigns, prenatal consultations, and we're going to find vaccine coverage indicators. And the third group will be even wider with the meningitis, TBA coverage, and all sorts of indicators which come in to support the data review. So we have all the elements that will allow us to decide whether or not we're going to do a validation survey. The second phase, when the decision has been taken to do this validation survey, the second phase will be a field visit in the districts to do a survey, to perform interviews, and it's going to follow the data review. And the visit will be held in the districts which appear less performing than the rest of the districts of the country. And the final selection, the final choice of district should not focus only on the performance indicators, but we must take other considerations into account, public health in general, considerations linked to finances, logistics, and often also the feeling of the national stakeholders from WHO. That's very important to decide which district, in which district to do the survey. And it's always supported by the data review, but it happens that sometimes 2 or 3 districts are on the same level. To choose and to have the feeling of the stakeholders in those districts. And we're going to do that in just one district generally, where sometimes we combine 2 districts, especially when we are looking at small districts in terms of population. In terms of statistics, we can sometimes combine 2 districts. And so, based on the assumption that, how can I say this? It's the worst case scenario. That's the word we use usually, which means that if in the district with the highest level of risk, if we can demonstrate that tetanus has been eliminated, that means that in the districts that are at lower risk or better in terms of performance, we can infer that they have eliminated tetanus.
But what will the survey focus on may appear simple, given that it's based on LQA, it may appear easy to do, but be mindful that it is a very intensive evaluation and also very complex. We must follow to the letter the dispositions. So it means a lot of preparing and also a very precise timing that takes into account all the aspects to generate quality data. We must also keep in mind that we will intervene in the most difficult places in terms of accessibility, in remote places, and also in isolated places. We must not forget that we are always in the worst case scenario. So it requires different expertise around the table. So you'll find the coordination team in the survey, vaccination specialists and pediatrician or specialists in neonatology or statistic people. Last element, very important, it is one of the few survey, at least as far as I know, it is a survey that can be invalidated before the final indicators are calculated. We can decide to invalidate the findings, which is if we have eliminated TN or not. During preparing, we have elements with pre-validation, with the implementation of a technical team on the national level who will lead this preparation. We have to do a briefing on the method itself. We must have a focal point on the national level who will do the link between the partners, WHO and UNICEF, and he will be in charge of all the coordination. He will manage the administrative side of things. So once the focal point has been selected, we must notify the district to initiate some local preparing. And together, we will see what are the best approaches possible to lead the survey. We must take into account climate, the seasons, the regions, and the major events taking place in the regions. We must put all of the best factors on our side, because as I said, it's a survey. We must ensure that there is an implication on the community level, at the community level. And maybe we can also involve the regional bureau of the WHO. So for the sample size, it must be based on the WHO guidelines. There is a spreadsheet which indicates us what must be the sample size based on the birth in the districts. According to this spreadsheet, we can do a simple sample size, and then we'll look at the result in the end. When it comes to the double type sample size, we have a first sample which is rather small. We do a data collection on it, and given the results, we can either choose to draw conclusions, or we can choose to go and have a second sample. And afterwards, we will select according to the methods and according to probabilities. We will keep in mind that the cluster is the interpreter. Sorry, but the sound is very cut. So should we do this sort of a micro planning? We need to prepare what is necessary. We need to ensure that all the teams work in the areas that are closest, and we must reduce transportation to the maximum, because we often intervene in zones that are quite remote. We'll then finalize the plan and the budget, and then we will identify all of the staff which will intervene the monitor, the supervisors, and the surveyors. So there will be a training that will be taking place. We have a national level training, which will implique all of those who were monitors. It will last 2 or 3 days. And there will be a second training, which ideally will take place in the selected district to carry out exercises. That is the place where we'll do the second training with supervisors, surveyors, and if maybe it's possible, data managers. It is recommended that the training takes place in the local language because there will be interventions in households, which is why surveyors are selected and are trained 2 or 3 days they will be trained for interrogation techniques. So to talk briefly about the staff, I talked about the surveyors. During the data gathering, they will be in charge of doing 1 cluster per day. They will work individually, and they're responsible for filling 2 out of 3 forms, and they will be in close contact with hierarchy. Their role is to identify all of the death and all of the pregnancies. There will ideally be nurses or nurses in the training. We want qualified personnel to lead the surveys because we will have to interrogate women on several intimate things that are linked to their marital life. So the female surveyors must be familiar with the local environment. We then have the survey supervisor, usually 2 or 3. They will be responsible for the planning within the team. Indeed, teams are made of supervisor, surveyors, and its chauffeur. They will be in charge of the day planning, and they will be in charge of all of the moving. He will lead the supervisor will lead investigations, and that's why ideally the supervisor should be a doctor or a health worker which has experience in investigation, and the supervisor will stay in contact with the monitor. The supervisor is in charge of handling the first stage review of all the data that were collected by the surveyors. Then there will be monitors which will be handling this group, and that will supervise at the highest level, and that will be in charge of the second session of the data review, whether it be on paper or electronically. But they will also have the possibility to work on a direct device. But so, as I said, there's this sort of a double investigation. Finally, the local guy, it helps the surveyor move through the community, enter household, and he is in pair with a local community responsible. Then the consultant or the international consultant, there will be coordinators for the surveys. They will be appointed by the WHO, and they will make sure that the WHO objectives are respected, and they will be in charge of intervening on reports, on briefings, and so on. So when it comes to questionnaires, we have 3 forms in this survey. The first is about all of the household data. It's where there will be live births that are eligible for this survey. And if there has been a neonatal death. On the second form, all of the live birth eligible will be registered here with a certain number of details. Gender, is the baby still alive? Information about the birth delivery context, who attended the delivery, was it with qualified personnel, was there postnatal treatment and care, what was there TT and TD vaccines, and so on. So it gives us information about the household and the mother. Third form, it is dedicated to investigations. If once a baby has been live birth has resulted in death, this is the form we'll use to lead the first step investigation. So this form is not filled by the investigator, it is filled by the monitor. It is a sort of verbal autopsy to identify the death causes. So to do a brief summary, the data gathering, the household data gathering, we won't go directly looking to death because otherwise it would be biased, but we will interview household door to door, and in each household we will have a look at the woman of reproducible age, and we will try to know if they are pregnant or if they have already been pregnant. If we have situations such as these, we'll try to monitor the pregnancy. We'll try to know if the baby has been born, if he has been born alive. Did it result in live birth? If it resulted in one or several live births, we will try to know if the child is still alive. If the child is dead, we will try to know when did the death take place, if it took place between the 1st to the 28th day, because it will be qualified as a neonatal death. This is the moment where the supervisor intervenes to lead an investigation and to determine whether or not it can be caused by tetanus. So all of these forms will be transmitted daily, whether by the supervisor or the monitor. Now we can do it with digital tools, but we will check with the server every night if there are any mistakes to send them back to the surveyor. So there are a certain number of elements that needs to be checked when it comes to data quality. It will be then compiled to make a final decision. Earlier, I was speaking about criteria. So first condition, all of the selected cluster must have been visited and completed. If a cluster is completed, the surveyor through door to door must be able to identify the number of live birth. Some have 10, some 15. It depends of the district characteristic. Second criteria, all of the birth and all of the neonatal birth that are in Form 2, we must have their equivalent in the Form 3. Third criteria, following the data collection, we'll be able to find at least 50% of the expected number of deaths. We can calculate it on a district level basis for the child birth death rate. And when you end your survey, you must have reached at least 50% of this number. About child inquiries, about 50% are boys. It is based on evidence and research. We must have 50 to 51% of boys, and the remainder are girls. So we must reach numbers within those approximation. So it's something that the surveyors must make sure of. They must focus on live birth. So on eligible live birth. So within the 24 month where there are eligible live birth. So this report must be followed. And there must be less than 10% of households that did not respond to the survey. So if there is a different number, it means that some things were not done properly. Must mean that some refused to participate or that we did not visit every household. So if one of these criteria is not up with the numbers, we can invalidate the number of neonatal deaths due to tetanus. To conclude, so if the neonatal tetanus threshold, if it is above the threshold, the district is given fail. If the number of neonatal tetanus death is below the threshold recommended by WHO, we can conclude that the district has passed the district for the given period. Given that we also collect other information, notably birth giving in good condition, it can also support elimination. So if TD2 is superior to 80%, or if SBA coverage is above 70%, we support elimination, as was said before. And as I said, if the elimination is seen within the district, then we can also conclude that this elimination has taken place. Thank you, Parinfo, for your excellent presentation that I find very, very clear. We have very few minutes before the 2 o'clock. Are there any questions? I have one, but amongst the participants, does someone have a question? We have 2 raised hands, but it's already 2 o'clock. So if you have a question, it better be short, please. Indeed. I had but indeed, yes, as you said, it's 2 o'clock. Are there raised hands? I don't see any raised hands. I have Putarat Uk and Dauda that have raised their hands. So they have the floor for a rather short question and a rather short answer.
Ils sont mute.
Are they
Putarak,
mute? Putarak?
Putarat, you can speak.
But
So I'll give you just a few seconds. If you don't open your mic, we'll give the floor to someone else. Okay, Putarat is not speaking, so we're going to give the floor to, well, we have Dauda and Lisette. Dauda already spoke, so I'm going to give the floor very briefly to Lisette. Lisette, you can speak. Please go ahead. Lisette, vous pouvez parler?
Lisette, you can speak.
Ça ne marche pas.
Si,
Maybe you may have to unmute the.
Lisette is unmuted.
Okay, let us.
Il y a un problème de connexion.
Okay, so if it's not working, I'm going to give the floor to Dauda. Okay, let me give the floor to Dauda. Dauda.
Yes, I'm here. Thank you for giving me the floor. Allow me to thank the Dr. Palemfo for the good presentation and for the fight in which he is impliqued. My question is about the validation criteria, the survey validation criteria. It has been said that if either one or two criteria have not been respected, the survey is invalidated. But if the survey is validated, when can we, what is the duration before we can organize another inquiry? First of all, we must avoid this decision because surveys are expensive and very time-consuming. When we invalidate a survey, we have to re-prepare and we have to redo the clots and we have to redo a team, the cluster, sorry. We have to redo a whole team. Other thing, when all of the elements are strictly followed and monitored, as it is the case now, we can anticipate on several quality problems. So it allows to stop the survey on the second of or third day of data collection and to strengthen certain elements. And so it allows us to stop at day 2 before going any further on a wrong basis. But ideally, in the best case scenario, it takes 1, 2, or 3 months. Thank you, Palinfo, for this very clear answer. It's already past 2 o'clock, so we'll put an end to this third webinar. We must thank the panelists and all of the relevant questions that have been asked. Thank you, Alexandre. You made sure this session carried out well. Thank you very much for everyone. Have a great end of day or have a great beginning of the day for everybody. Thank you very much. Thank you very much, everyone. Merci beaucoup, Alex. Merci, François. Merci, Palinfo. Et merci, Amadou, pour votre soutien.